All right. I'm Sara Jane Schwarzenberg. I'm the Chief of Peds GI here at this fine university. And I'm going to talk today about total pancreatectomy and islet autotransplantation. And I chose to talk about this for two reasons. First of all, we have a lot of patients on the ward who get this procedure, TPIAT. So you guys are going to come in contact with these patients a lot. But secondly, this procedure was developed and pioneered at the University of Minnesota. And when you go to other places, you can be justifiably proud that a procedure that is now done to relieve pain across the world was pioneered at your university by David Sutherland. Is there any chance I can get this right? Okay. I have no significant disclosures about TPIAT. I'm going to talk a little bit about chronic and acute recurrent pancreatitis and the impact of chronic pancreatitis on the health of children. I'm going to talk about treatment options for chronic pancreatitis. That won't take us very many slides. And then I'm going to talk about TPIAT, and in particular, I'm going to talk about the outcomes of TPIAT, because I think as residents and as faculty at this university, you see the inpatients, the people who've just had a major surgical procedure, who are in pain, who are having all kinds of health problems, but you don't see the kid who hugs us a year out in the outpatient setting. And I want to give you some idea of how that really goes. So the pancreas is a wonderful organ. It is small, but it requires 2 medical divisions to manage it, okay? Very few organs can say that. Pancreatic function is both exocrine and endocrine. The pancreas produces about 1 liter of bicarbonate-rich fluid every day. And within that liter of fluid are the enzymes that digest the majority of proteins, lipids, and starches. It also has endocrine functions. It makes glucagon and insulin and also somatostatin and pancreatic polypeptide, which is important in the GI tract. I don't want to say the GI tract is the most important organ in the body, but you know, we know it is. And pancreatic polypeptide is very important there. Now, there are 3 kinds of inflammatory diseases of the pancreas. And it's really important that you keep these separate because these 3 diseases are diagnosed and managed in different ways. The first is acute pancreatitis, which is also the most common. In acute pancreatitis, you have devastating inflammation of the pancreas, but you have complete recovery to the point where we could go in and look at your pancreas 6 months later and we wouldn't be able to tell you ever had pancreatitis. Acute recurrent pancreatitis, that is more than 1 episode of acute pancreatitis, but with complete recovery in between. So even 2 episodes of pancreatitis, if they are separated by a period of recovery, constitutes acute recurrent pancreatitis. And that's important in how you manage this disease. And then there's chronic pancreatitis. Chronic pancreatitis is a persistent, destructive, inflammatory lesion in the pancreas. A lesion that we cannot stop. So once started by whatever mechanism, whether it's obstruction of the ducts or some toxic injury to the acini of the pancreas, there is no stopping it. There's no ending that inflammation, and it progresses to the destruction of the pancreas. That may not occur in your lifetime, or it may not occur, it may occur in 2 years, it may occur in 10 years, it may occur in 50 years, but the destruction is unstoppable. And that lesion never goes back to normal. People who have chronic pancreatitis may have flares, and they may go back to periods where they have no pain, but if you were to look at the pancreas, it would be abnormal. Chronic pancreatitis is not common. It occurs maybe in children, maybe 375 cases a year, but those cases take up a disproportionate amount of hospital beds. So these people are in the hospital sometimes 17, 18 times a year, coming in for pain, going out, staying about a week at a time. So while there's a small number, they have a large impact on our healthcare system. acute recurrent pancreatitis and chronic pancreatitis will probably present to you in a manner very similar to acute pancreatitis. There are intermittent episodes of what looks like acute pancreatitis. These patients have abdominal pain that characteristically goes through to the back. Not always, but that is a big clue. When people tell you they have pain in the mid-epigastric region and it goes through to the back, that is a big clue that this patient could have pancreatitis. They vomit or are nauseated. And interestingly, early on, in the first few episodes, they may have elevated amylases and lipases, but later, after many episodes, they either cannot mount enough amylase and lipase to have an elevated serum amylase and lipase, or their pain has now moved from the pancreas itself to the peripancreatic area. So they're experiencing what seems like pancreatic pain. They're truly in pain, but their amylase and lipases don't go up. So be very cautious. I cannot tell you how many patients I have seen who have chronic pancreatitis, but have also been saddled with a diagnosis of IBS and refused opioids at a time when they're in agonizing pain. Not in my emergency room, but in others. The pain may resolve after an episode or may continue at a low-grade level. Once you're having daily pain, you probably de facto have chronic pancreatitis. It's important to eliminate other causes of pain, not only because they can cause pain, they can fool you into thinking you have chronic pancreatitis or acute pancreatitis, but they can accompany chronic pancreatitis. The opioids we give people can make them constipated. The disease itself can lead to esophagitis and gastritis, and delayed gastric emptying often accompanies chronic pancreatitis. Importantly, this disease is often missed in children. The lag time between the first real episode of pancreatitis and the diagnosis in young children can be years. And we have stories, probably the worst story I've ever heard is of a young child whose parents would send him out to the barn to scream when he was having these episodes of pain. Nobody had diagnosed him. Nobody had ever drawn an amylase and lipase on him. And so the parents thought that he was lying about his pain, when in fact, he was having terrible episodes of chronic pancreatitis. So we have seen kids as early as 6 months of age who have genetic reasons for chronic pancreatitis come in with episodes of acute pancreatitis. So you've got to have a high index of suspicion. So what are the causes of chronic pancreatitis? Well, in adults, we say that more than 50% of chronic pancreatitis is related to alcohol and smoking. And in fact, cigarette smoking is probably a bigger risk factor for chronic pancreatitis in adults than alcohol is. However, we don't do genetic testing in adults. And when you do genetic testing, you sometimes find that the individuals who have what we call alcohol-related chronic pancreatitis may also have genetic risk factors. That's not a surprise. This is not a disease where one thing leads to disease. This is a disease where one or more different things, some environmental, some genetic, conspire to create chronic pancreatitis. In children, we know that 2/3 of children who have chronic pancreatitis, at a minimum 2/3, have a genetic risk factor. Now, why do I say risk factor instead of cause? Because if you look at the SPINK1 mutations, a huge portion of the general population has SPINK1 mutations. We believe there has to be a second hit that takes this individual with a SPINK1 mutation to chronic pancreatitis. PRSS1, well, that one's a little different. There's pretty good penetrance for PRSS1. Still, I frequently see kids with terrible chronic pancreatitis associated with PRSS1 mutation who have parents who have the mutation. It's an autosomal dominant disease, and who have no pain whatsoever. So it is possible to escape the pain of even PRSS1. PRSS1 is what you guys probably learned in medical school as hereditary pancreatitis, an autosomal dominant disease that is more common in the southeast of the United States. among the people I grew up with in Appalachia. But we have pockets of PRSS1 in Minnesota, particularly in one or two of the Mennonite communities. So you will see this in this state. CFTR mutations, a very interesting form of chronic pancreatitis that occurs only in people who are pancreatic sufficient with cystic fibrosis. If you're pancreatic insufficient, your pancreas was probably destroyed in utero. You can't mount a chronic pancreatitis response or a pancreatitis response. But if you are pancreatic sufficient, you have function and you can. About a third of children have a congenital obstructive lesion of the pancreatic duct, and about half of them also have a genetic risk factor. So this is the more than one thing causing chronic pancreatitis. So how do you diagnose this? Well, it's a combination of clinical, functional, and anatomic findings. You know, the ideal would be to show that the patient has decreased pancreatic function. It's very hard to do. You have to lose about 90% of your pancreatic function before you begin showing disease. So you don't need pancreatic enzymes until about 90% of your acinar function is gone. So it's very unusual in children to diagnose chronic pancreatitis using that. We more commonly demonstrate morphologic changes. The modalities used for imaging in chronic pancreatitis have really changed over the years. Ultrasound, which is what everybody would love to say is our first step, frequently does not show the pancreas. There's air over the pancreas and you can't see it. So we're usually going to a secondary imaging strategy like CT or MRCP. Of the two, you want to use MRCP because MRCP is radiation free. You would like to avoid CT scan in these patients because they are likely to have multiple imaging procedures in the course of their lives. And MRCP can give you a magnificent view of the pancreas. Combined with secretin, it can even give you some information about pancreatic function because you can see the flow of pancreatic juice in the ducts. Years ago, we used to use ERCP as a diagnostic tool. Nobody should use ERCP as a diagnostic tool anymore. ERCP is reserved for treatment. It's a therapeutic modality, stenting the pancreatic ducts, opening up the bile ducts, whatever needs to be done, but it is not used anymore as a diagnostic modality. So good to know. We also have access here at the university to endoscopic ultrasound, which can be really helpful, particularly if you think you see a mass in the pancreas or you have some ambivalence about whether or not you're seeing enough morphologic changes in the pancreas to diagnose chronic pancreatitis. This is a CT scan. The arrows are showing an inflamed pancreas. And here is an MRCP of chronic pancreatitis. And the arrows are pointing to ducts. Oh dear. Okay, that was not the right thing to do. Okay. Oh, that's not so bad. The arrows are pointing to ducts coming off of the main pancreatic duct. Does anybody know how you get the... Oh, okay. So this is the pancreatic duct. It's large, it's enlarged and tortuous. It should really be smooth and nice like this, but it's enlarged and tortuous. And coming off of it, you can see side branches. You should never be able to see side branches on an MRCP in the pancreatic duct. When you see that, something's wrong. And in this case, it's chronic pancreatitis. Calcifications are pretty much pathognomonic of chronic pancreatitis. Unfortunately, children are much more likely to have atrophy of the pancreas than to have calcifications. But once you see them, that you're pretty much done. So what's the impact of chronic pancreatitis? Well, I cannot overstate that pain is the major problem with chronic pancreatitis. Yes, it's sad for people to lose their exocrine function and have to go on pancreatic enzymes. Yes, it's terrible for people to lose their endocrine function and have to go on insulin. Both of those things are things that nobody likes. But what really devastates children and adults and what destroys their lives is pain. And the pain is horrendous. It is unrelenting. For many of them, it is happening every day, and it has tremendous impact. They lose work and school time. They have recurrent hospitalizations. They're not being hospitalized because their exocrine function's getting worse. They're getting hospitalized because they're in agonizing pain. They are at risk of pancreatic insufficiency, and they're certainly at risk of addiction to opioids or other substances. In one study, I'm part of a large cohort study in chronic pancreatitis in children, the INSPIRE study, and in a large number of children from all over the world with chronic pancreatitis, the average, 29% of those children on average were in constant pain in the last year. This is a group of close to 100 children. The median number of days of school lost in the last month was 3. They're losing 3 days of school a month because of chronic pancreatitis. And interestingly, in this group, surprisingly, the rate of exocrine insufficiency in children was 1/3, which, I think is a very surprising finding for a group of children who have not had disease that long. When I was a medical student and resident, and even on into my practice, I was told that chronic pancreatitis would eventually burn out. That over time, the pancreas being injured over and over and over again would eventually just burn out. Your pain would go away. Yeah, you'd be diabetic and you'd require pancreatic enzymes, but you wouldn't have pain anymore. Okay? It turns out that that really doesn't happen. Yes, it's true that if you follow groups of people with chronic pancreatitis, they will eventually become exocrine insufficient. Their acinar cells will be gone. Their islet cells will be gone. But in most patients, their pain will continue. And one of the reasons it continues is that chronic pancreatitis pain is not just from the pancreas itself. It's from the inflammatory tissue around the pancreas, and it's from the severe visceral hyperalgesia that occurs because of years of chronic unrelenting pain, okay? So I think it's really important to realize that you can't just say to people, okay, yeah, you're in pain now, but in 10 or 20 years, it'll all be gone, so it's okay, and just live with it until then. You really have to do something to manage their pain. So that people who have chronic pain achieve less in life, they go to less school, they do worse in school. All of these things seem like, does to me, but it's good to know that you do have data behind you. So chronic pain needs to be relieved. So in summary, chronic pancreatitis is a severe and life-altering disease process. Chronic pain and loss of function impact quality of life. The pancreas may burn out in a couple of decades, but it's going to leave you with endocrine and exocrine dysfunction, and you may have continued pain. So what do we do about it? Well, the truth is we have very limited therapies for chronic pancreatitis. If you drink and smoke, you should stop. Okay, and actually that's very powerful. People who have alcoholic pancreatitis, if they stop drinking, their pain gets dramatically better. Unfortunately, for most of my patients, that's not one of my treatment options. You can use non-enteric coated pancreatic enzymes, which has a very tiny chance of perhaps making your pain better, but really the data is very poor. Antioxidants, there may be 2 papers in the literature, one of which is in a form of pancreatitis we rarely see in this country, a form of tropical pancreatitis. Again, a marginal improvement in pain. Steroids are only available for autoimmune pancreatitis, which occurs in about 2% of the episodes of chronic pancreatitis in children. You can do ERCP for intervention, but you can't do it for very long. So often, you can go in through ERCP and remove stones in the pancreatic duct and reduce pain dramatically, okay? The problem is they reform And often you have to go in every 3 months and continue removing those stones. And each time you enter the pancreatic duct, you put the patient at risk for an episode of acute pancreatitis, which can be quite severe. And you also introduce bacteria into the pancreatic duct, which can then go on itself and begin damaging the islet cells. So it really is something that works short term, but it's not going to be something that you're going to be able to continue in a child for 80 or 90 years and maintain the child pain-free. If you have gallstones, you should have your gallbladder taken out so that it doesn't keep shooting sludge and gallstones into your pancreatic duct. And I say that because, interestingly, I'm learning that across the country, that's less recognized in pediatrics than it is in adults. I think the first thing that happens in adults is you get your gallbladder yanked after a couple of episodes of pancreatitis, but not so much in kids, and we need to be aware of that. Conventional surgical procedures are quite devastating, okay? The conventional surgical procedure that is most commonly done is some variation of drainage or decompression. And the most common surgical procedure, the abdomen is opened, the pancreatic duct is filleted open lengthwise, and then a roux is made from the gut, and a piece of gut is stuck up to this now filleted pancreatic duct to improve drainage, okay? And some people can get 5 to 8 years of pain relief from that. There can be prolonged pain relief. First of all, you have to have a very big pancreatic duct, and very few children have pancreatic ducts that bad going into this procedure. Secondly, you heard that 2/3 of children have a genetic risk factor as the cause of their pancreatitis. They're not going to be able to get rid of that genetic risk factor. So something that relieves your pain for 5 or 6 or 10 years is not going to keep you pain-free for 80 years. And it's really important to think very carefully before doing one of these procedures in children, and I will explain to you reasons why that is later. So pancreatitis may recur, particularly in genetic-based disease. A lot of people try nerve blocks on people with pancreatitis. Nerve blocks are awesome if you have pancreatic cancer. If you are a child with chronic pancreatitis, you can damage the nerves, and the nerves themselves that you have injected alcohol into or cut can begin causing pain. So again, you're looking at an 80-year window when you're talking about a 10-year-old, maybe a 90-year window. You have to do something that isn't going to make them worse after 10 years. Okay, so David Sutherland, who is a surgeon here at the University of Minnesota, in the 70s perceived this problem, all right, the problem we've been talking about in chronic pancreatitis. And at the time, he knew that if you took the pancreas out, you just took the pancreas out and you put it in the trash can, for most people, their pain would go away, okay? But they were exocrine insufficient. They had to take enzymes for the rest of their lives, and they had terrible diabetes, right? So along with people here at the university who were studying islet cell function, he conceived of the idea of isolating the islet cells from the pancreas and putting them back into the person to alleviate diabetes. Now, he put them in a lot of crazy places, and he started out, of course, in dogs. He did not start out in humans. There were some mice, too. I hear that Kathy Bendel was involved in some of this islet isolation research, in the day. But ultimately, he ended up putting them into the liver. And we know that the liver is the most sacred organ in the body, and so ideally suited to taking on the islets. And he perfected, really, this procedure of total pancreatectomy, islet autotransplantation. And I don't want you to think that the history of this procedure is one of delighted acceptance by the world as soon as he brought it forward. As late as 7 years ago, my fellow, one of our fellows who was presenting a child who'd had TPIAT at a national meeting, was called out as unethical for doing these procedures in children, okay? I'd like to have, 20 or 30 of my parents who've had kids who've had TPIAT speak to that person. But I think that the point is that it's been a rocky road to acceptance for this procedure. So in this procedure, the pancreas is removed. The spleen is also removed because of vascular compromise to the spleen during the removal of the pancreas. And a Roux-en-Y is formed to allow bile duct drainage to be restored. And while all this operation is occurring, the pancreas is sent to a lab on the St. Paul campus, and the islet cells are purified from the ground up pancreas, okay? Ultimately, the islet cells are injected into the portal vein, okay? This is, I got to tell you, it's amazing to me always that these islet cells go into the portal vein and then they regulate glucose the way they would if they were sitting in the pancreas. But, what can I say? They're trapped in the sinusoids of the liver, and if you treat them very, very well, they can replicate and turn into little islands of islet tissue in the liver. Islands so big that you can see them on a CT scan. And I know this because every once in a while somebody sends me a CT scan and says, the patient you did a TPIAT on has cancer. Okay? Well, no, they don't have cancer. They have little islands of islet tissue sitting in their liver. These are islets growing. Now, the beauty of this is that these are the patient's own islets. You don't need to use immunosuppression. There's no risk of rejection. You just have to keep them healthy. You can't let them have hepatitis. You can't let them get alcohol poisoning. You have to take care of your islets that are now in your liver in a place where, toxins tend to flow. So you have to be careful. The primary indication for TPIAT is pain, unrelenting pain in the setting of chronic pancreatitis and acute recurrent pancreatitis. That's really important. If you come to me and you have PRSS1, okay, you have the worst mutation possible, and you have an episode of pancreatitis twice a year. Twice a year, you're in the hospital for 5 days each time, and in between, you're fine. You're playing sports, you're going out with your friends and eating pizza, you're doing all the things that kids should do. I will not offer you a TPIAT, okay? It is not offered to prevent cancer. It's not offered for any other reason than for pain. So it's really important to understand that pain is the indication for this surgery. The goals of surgery are the treatment of pain from chronic pancreatitis, decrease the complications of long-term opioids, and preserve islet function. So how well do we do? So the clinical characteristics of patients undergoing TPIAT in Minnesota, 85% are adults and 15% are children. In children, it's about 1-to-1 males and females. And there's pre-existing diabetes in about 8%, okay? Post-operative management is extremely rigid. For those of you who've been on the ICU or taken care of these patients, you know that Melina Bellin here at this university, who you got to understand is an international expert in islet cell function after TPIAT. I mean, she is just known all over the world. Melina Bellin pioneered the tight glycemic control after TPIAT that prevents the islets from undergoing beta cell apoptosis and allows them to proliferate and grow. And our outcomes are better than anyone else in the world because of her work. So that's really important. Pain management, this is a huge procedure. This is a big procedure. People are under anesthesia for many, many hours, and they come out with a lot of pain. And we are fortunate to have an excellent pain team that creates a pain plan before the patients come out of the operating room and then follows them through the procedure and on into the outpatient setting. They require early enteral nutrition So a GJ tube is placed when they're in the operating room, and jejunal feedings are started very, very early. And of course, they're going to need lifelong pancreatic enzymes and fat-soluble vitamins. They're treated in many ways nutritionally very similar to cystic fibrosis patients. And of course, they all have had their spleens out, so they need pre-operative vaccines, and then they need post-operative splenectomy precautions. So what are the outcomes here? Okay, so we do this enormous procedure, this aggressive, enormous procedure for pain. And I'm going to talk about several outcomes. The first is mortality. Early mortality in TPIAT is less than 2%, and this is both adults and peds combined. We have had a couple of deaths in children at the University of Minnesota, so it's not zero by any means. It's a big procedure. Neither of our deaths were early deaths. They were all late deaths, but they were deaths nonetheless as the direct result of the procedure. The survival after surgery for both adults and children is excellent, and people have said that long-term mortality is not related to the operation. But I question that. If you go to the literature and you look at all of the reports of TPIAT across the world, and you look at the causes of mortality, particularly in adults, you'll find several where they report suicides or very, very unreasonable car accidents that could easily be suicides. And I guess I would argue that we're not tracking mortality in this procedure very well, and we don't know that there isn't a slightly higher mortality than is being reported, particularly in adults, some of whom don't get quite the pain relief that children do, as I will show you in a few minutes. So I think that's an open question. Morbidity is significant. This is a major surgical procedure. These patients are very ill. Most of them are somewhat malnourished because of the pain and nausea associated with intake of food. There are complications associated with splenectomy. Most of them have gastric dysmotility. They have gastroparesis immediately after the procedure that in children commonly lasts at least 2 to 3 months. They require jejunal feedings for 2 to 3 months. However, some of them never recover, particularly among adults. So you have to be aware that that is a risk, that they will never have complete motility of their stomach. Most of them can eat something. Not all of them can eat everything to keep themselves well nourished. And there's a really high rate of gastrointestinal symptoms post-operatively, particularly diarrhea and steatorrhea. And one of the problems that we found is that we do patients all over the United States and Canada, and we send them back sometimes to people who have no notion of how to manage pancreatic enzymes. And that's a real big problem because they come back and they're getting one capsule of Zenpep or something. And that's totally inadequate, and a lot of their pain, their diarrhea, their malnutrition is associated with inadequate management of their enzymes. Very young children exhibit normal growth in the 2 years following TPIAT. They, of course, as I said, are reliant on pancreatic enzyme therapy. And if you ask adults and children, 80% of them will tell you that they are completely adherent to their pancreatic enzyme therapy. But in a study of adults with chronic pancreatitis, of the ones who were pancreatic insufficient, demonstrated to be pancreatic insufficient, only 60% have been given a prescription for pancreatic enzymes by their doctor. I mean, you know, their doctor knows they're pancreatic insufficient, but 40% of them don't give them a prescription for pancreatic enzyme therapy. And of the group who had a prescription for pancreatic enzyme therapy, only about half were taking them. Now, there are reasons for that. You live in a world where most of the people who are pancreatic insufficient have cystic fibrosis. And cystic fibrosis is considered an indication for pancreatic enzyme therapy by insurance companies. Surprisingly, pancreatectomy isn't always considered an indication for pancreatic enzyme therapy by insurance companies. And it can be tremendously difficult to get the insurance company to pay for what is an incredibly expensive therapy. Schwachman's usually gets paid. Many of you have worked with me on a kid with Pearson's pancreas marrow, not an indication, even though that child has documented pancreatic insufficiency. So insurance companies become a real problem in some of these situations in terms of providing adequate therapy to patients. Pain relief. So I told you that was the primary goal of this procedure. So the statistics say that 94% of individuals have complete or partial relief of pain after TPIAT, and this certainly exceeds the pain relief of any other procedure that is done for chronic pancreatitis. And we're going to drill down into this a little bit more. 15 to 30% of people, mostly adults frankly, at the University of Minnesota pancreas program report persistent pain. In Minnesota, I'm sorry, that's nationally. In the Minnesota study, only 7.5% of adults reported persistent pain at 1 year post-operation. Now, opioid use in the same group at 1 year was 34%. So it's hard to balance this 7.5% pain and 34% opioid. I realize that some of these patients may have been opioid tolerant or opioid attached, but really there is an inconsistency there. The factors that are associated with persistent pain include pancreas divisum, which is probably a surrogate for multiple previous ERCP procedures, previous Whipple resection, obesity, and more than 3 previous stents. So when you look at pancreas divisum and more than 3 previous stents, you're probably looking at the same thing. What about very young children? So we've done 17 children who are age 5 to 8 with chronic pancreatitis, and we followed them for about 2 years. And all of them had complete pain relief. Children do really well with this procedure. They've had pain for less period of time. They've generally had fewer ERCPs. None of them have had Whipples. There's a lot of things that make children candidates for real pain relief with this procedure. All of them had discontinued opioids by 1 year. So 90% of children have improvement in pain scores. Dr. Bellin has done quite a bit of work with health-related quality of life, and has shown that in both adults and peds, SF36, which is a measure of, general measure of health-related quality of life, scores improve dramatically after TPIAT for chronic pancreatitis. And they have fewer days of limited activity, dramatically fewer days of limited activity. I mean, these kids are playing soccer, they're playing tennis, they're going to school, they're doing the things that kids should be doing. Whoops. And again, pediatric patients had better outcomes compared to adults. The dark blue is narcotic use, and you can see on the left in children, narcotic use is much less in children after this procedure than in adults, and many fewer children have persistent pain. Parents are delighted by this procedure when you ask them about their child's health interfering with school attendance or how many days per month your child is limited in activities. You can see that compared to before the procedure, that things improve dramatically after the procedure. And this is exactly what you want. You want to return these kids to normal life with pancreatic enzymes. Health-related quality of life is diminished in the majority of people who have chronic pancreatitis. And if you look down at the children, 38 children with chronic pancreatitis reported diminished health-related quality of life and increased fatigue versus healthy normals. This is in chronic pancreatitis. But after TPIAT, if you look, the blue are people with no opioid use, and the red are people who continue opioid use, despite the fact that people with opioid use have worse health-related quality of life for both social function and role physical limitations than people who get off opioids. They both improve dramatically. All groups improve dramatically. So in the modern era, insulin independence 1 year after surgery is a really crucial measure of how well we're doing with this procedure. And about 30% of adults are insulin independent 1 year after surgery. There's also about 30% who only require one insulin injection a day. Now, you could question, I mean, if you have to take insulin at all, isn't that a failure? But in fact, that is not. People who have zero insulin have diabetes that is much more difficult to control than people who have a little bit of insulin. As a gastroenterologist, I wouldn't necessarily know that, but Melina Bellin assures me that that is true, okay? So even having partial function of islets in your liver is a good thing after TPIAT. What are the correlates of islet outcomes? Some of the factors include higher islet number being transplanted into the liver, and I'll show you more about this in a minute. How healthy those islets are at the time of transplant. Shorter duration of disease, which may well be a surrogate for islet numbers. Non-calcific disease, which may be a surrogate for islet numbers. And young recipient age, which I'm going to show you in a minute, gives you a lot of positive outcomes for islet independence. So this is insulin independence in a series of adults and children. The open circles are adults and the cross hatches are children. My thing didn't show up very well. And you can see that children acquire more insulin independence than adults do when you get out to 36 months after TPIAT. But the other thing I want you to look at is the slope of the line. If you look at the slope of the line for adults, it's pretty much flat. So once you get much beyond a year after your TPIAT, it's unlikely that you are going to become insulin independent. Whatever you are at a year is probably what you are, okay? But if you are a child, you are still on a slope upwards up to 36 months after your TPIAT. That's a very hopeful thing. And it's even more hopeful if you're very, very young. So the green line are children who had their TPIAT between 13 and 19 years of age, and the blue line are children who had their TPIAT between 5 and 12 years of age. And as you can see, not only do they both achieve a fairly high percentage of insulin independence, but these very young children are still on the upswing a year after their procedure. So there's a chance that more of them will become insulin independent with time. Does insulin independence wane? Well, in adults it may. If you look at the data from the University of Cincinnati, who have done 116 adults, there is a loss of insulin independence after 5 years. But studies in children suggest that insulin independence is sustained over 10 years and may be sustained longer. So I think it's, again, children seem to do better with this than adults. They've had the disease for a shorter period of time. They often get more islet cells, and they have fewer other diseases impacting their results. Higher islet mass is very important. If you look at the left-hand column, this is the percent who become insulin independent. The x-axis is the time after TPIAT in months. People with an orange bar got greater than 5,000 islet equivalents per kilo, and you can see that their insulin independence, even after 36 months, is much higher than those who got 2,500 to 5,000 or less than 2,500. It's not that you can't be insulin independent at these lower levels, but it's just less likely, okay? So getting more islets out is better. And prior drainage procedures. You remember I told you that I was going to tell you why drainage procedures were not a great idea in somebody with a genetic risk factor for chronic pancreatitis? Well, this is why, okay? So people who have had surgery, who have had no surgery before TPIAT, get somewhere between 3,500 and 4,000 islets out of their pancreas. And even if you've had a Whipple, surprisingly, things don't go down very much. But if you have a drainage procedure, it will definitely reduce the amount of islets that come out of your pancreas. Infection is being introduced into the pancreas, scarring is being introduced into the pancreas, inflammation is being introduced into the pancreas when you do these drainage procedures. The gut's a dirty, dirty place. When you hook it up to the pancreatic duct, it's going to make a mess, okay? So it's not surprising, but it's an important thing to realize. So when you're dealing with a child with PRSS1 and somebody says, well, why don't we temporize with a drainage procedure? You may be ending that child's capacity to ever become insulin independent. In the procedure, they're almost certainly going to have in the future a TPIAT. Oops. Long-term follow-up is really critical in these patients. We get our best outcomes when we see them frequently, when we manage their malabsorption symptoms and give them appropriate pancreatic enzyme doses. We have to monitor them for fat-soluble vitamin deficiency, and we do routine labs every year. Not everybody comes back to us every year, but we feel strongly that you either need to see a pediatric gastroenterologist with expertise in the pancreas, and there are not many of us, or you need to be seeing us. You need to see somebody who knows what they're doing. So this is an incredibly aggressive surgical procedure with a high risk of morbidity. But in selected patients, it is a life-changing procedure. And the kid that you guys are seeing on the ward, who's in terrible pain after this procedure, is the same kid who's hugging me in the office and thanking me and thanking our team for getting them back into school, for getting them back into soccer, for letting them live their lives. And I really wish all of you guys could see that part, you know, because I think it's I think the work that you guys do to take care of these patients pays off. And it's too bad that the outpatient setting people are the only people who get to see that. Small numbers of these people have poor outcomes. And right now, a major thrust of research is trying to identify these people ahead of time, so people who are at risk for poor outcomes, and trying to prevent these poor outcomes. So I want to thank you for listening to me. This is the combined adult and pediatric TPIAT team at the University of Minnesota, photographed on a winter day, okay, because it is Minnesota after all. Thank you. Yes.
Great talk. I really enjoyed that. How close are we to transplanting auto stem cell derived islet cells?
I would have no idea. The person who would know is Melina, I would think. Is she here? Okay, do you know?
I know that we are continuously getting closer, but you know, the issue with non-autologous transplant is, first of all, it's been doing a type 1 diabetes, so there's autoimmunity and alloimmunity attacking those islets, and the need for anti-rejection drugs. As far as stem cell islets, there are lots of people now who can make islets from a variety of tissue, but who still can't control them, and that's the problem. They have to respond to glucose by making insulin and then stop making insulin when the glucose is not there. But there's progress being made.
Thank you. It was a great talk. One thing that I did want to mention about for pain control too is that Yes, we see the great numbers for that, and that's something that the patients want to come in, and that's their ultimate goal, and we get them there. The thing that needs to be stressed for these patients too is that this procedure is not the immediate fix for pain control, that it takes a lot of work between the procedure and even a year later of constant physical therapy, psychology, lots of work on their behalf in that intervening period, which some of them aren't prepared for to do, but that's what we're working on. But that's also very, very important for these patients to know.
Yeah, I think that's fair. I think that when I talk to patients in clinic, I tell them that this is not like an appendectomy where you get your procedure and 2 days later you're great. This is a procedure where the day you get the procedure is the start of a year where you're going to slowly recover. And it's probably longer than that. It's probably a year or two. The impact, pardon me? Right. No, their problem's not gone because they've had, and Matt could speak to this better than I could, but they've had years of pain. So they have visceral hyperalgesia, and that is going to take a tremendous period of time to control and manage, and may never actually go away, but will get better probably over a period of years. In addition, most of them are on opioids, usually before the procedure and after the procedure. The rule of thumb is if you're on opioids and you stop, it takes a year for your colon to recover. It takes a year for your gut to recover from chronic opioids the day you stop. So the day you do the procedure is not the day they get well. It takes a long, long time. Anything else you want to say, Matt? Okay. Yeah.
So that was great, Surgeon. I'm curious about the sort of slope of insulin independence continuing. You know, there's an upgoing slope, as you pointed out. My presumption is that reflects proliferation of the islet cells. So if that's true, are there strategies to enhance that?
Melina Bellin is actually doing some studies in adults on that. And Tony can answer the question.
She's tried sitagliptin because it's a DPP-4 inhibitor, so there's some animal evidence that perhaps incretins can encourage beta cell proliferation, but the sitagliptin trial that she did was negative. It didn't improve it.
Sarah Jane, that was a wonderful talk. For everybody in this
audience, who don't know, this is Dr. Srinath Chinnakola, who is our transplant surgeon and excellent, both as a partner and as a surgeon.
Thank you. So one of the most important thing I want to acknowledge to everybody in this room is that it takes a leader to make an internationally recognized program, and Sarah Jane truly has been a wonderful leader in this. She's very passionate about this. This is one of the very few programs in this institution that is recognized internationally. I think Sarah Jane gets full credit for that.
I would have said Dr. Bellin gets full credit for that.
No, truly, the thing is, Sarah Jane is a little bit humble. She tries to give credit to others. But every day I come to work, she's very passionate about this group of patients. She advocates for them. She fights for them. She fights with the administration to get resources. Not only that, she provides an umbrella under which junior faculty can work. I mean, Dr. Bellin is not here, but thanks to the leadership from Sarah Jane, Bellin has gotten 2 NIH grants. This is purely work of the team, and I think that is extremely important to recognize. And one of the other things I want to point out is that in this day and age, truly to achieve higher heights, you have to have a multidisciplinary approach, collaboration between departments. And this is one wonderful area where there is collaboration between the surgeons, the gastroenterologists, the pain management, interventional radiology, endocrinology. So I think it's very critical for the younger generation here to recognize that, you know, the days of being a lone wolf are gone. I think you have to collaborate, and truthfully, when you collaborate, you can achieve more than what you can achieve individually. So that is, I think, very important. And once again, I know Sarah-Jane is very humble and doesn't like to take credit, but I really think she is truly a leader in this field, provided an umbrella for junior faculty in the Department of Pediatrics. Joe has left, but I will certainly want Joe to know that that has been truly an important observation that I have made. Thank you again, Sarah-Jane.
Thank you very much. But I think the part about the team is really, really important. We are the envy of many other centers that do TPIAT and our own adult colleagues, because we have awesome pain management, amazing endocrinology, a wonderful surgeon, and we all work together. You know, we're not fighting each other on the wards. We're making plans together. We're creating a way to manage these patients together. Yeah.
Is there something special about the islet cells that lends them to surviving this procedure that acinar cells don't have?
Really am going to have to talk to Melina about not coming to my grand rounds. I don't know. What do you think? Tony's probably the only person here who can answer that question.
You know, the thing that's most remarkable, I think, about the whole procedure is that you can take islets from the pancreas and put them in the liver and they work. And part of that is the portal circulation and that they are at least still seeing the glucose coming from the gut, the protein coming from the gut.
But you can put them in the peritoneum. You can put them under the skin in the arm. And they work. I mean, they just...
So they're responding to glucose in the blood, but acinar cells have to secrete substances into ducts that will then get them into the gut. And I think just I can't say anything about their survival, but just the technical issues of getting them in the right place is a lot trickier.
Yeah.
And it's a lot easier to take digestive enzymes than insulin.
Absolutely. Absolutely. You wouldn't know that to talk to the patients sometimes, but yeah, it is. Yeah.
Thanks, Sarah-Jane. Great talk. 2 questions. What's the approximate length of hospitalization for this procedure, and how many other centers in the country do this?
So I think our patients are in, 4 weeks, sometimes 6 weeks. There's the occasional patient who's in much longer and the occasional patient who's out after 2 weeks, but that's 4 weeks is probably about average. If you're talking about TPIAT as overall, you know, there's probably 10 or 12 really viable programs in the country and very few to none in Europe and Great Britain right now. I think Great Britain closed their only program. There's one place in Canada that's trying to do islet cell transplant, but they're not doing much. But if you're talking about children, there are maybe, counting our program, 1, 2, 3, maybe 4 in the country. And 3 of them are probably decent programs. I mean, I think if I were looking for a program to take my child to, I would want one where there was a gastroenterologist, an endocrinologist, a pain specialist, and a surgeon who worked together. I think the problem with some programs is that they're started in a surgical arena and no other subspecialists are really brought into the program. I think that's why we all value Dr. Chinnakotla and his collaborativeness so much. It's a mutual admiration society, you're right. Thank you, you guys.